always been a very intriguing and interesting topic for everyone. However, sadly, it is the most neglected topic during education, because in examination usually ECG is not asked, or if it is asked, the expert tells the diagnosis. So proper formal training or diagnosis, ECG diagnosis, usually is not possible in a normal MBBS course. But ECG is very important. Now you will see so many ICUs, so many critical patients, they are there, and these are managed by our residents who don't have a formal training of ECG. In fact, so they have to rely on the computerized diagnosis of ECG. So many general practitioners in the periphery, they have purchased ECG machine which gives a computerized diagnosis, which many times is wrong. Sometimes it can be correct, but many times it is wrong. And on the basis of that is, in fact, a 15-16-year-old boy with chest pain, computer trace possible entry infarction, and that patient is referred for further investigation, angiographies. So I was thinking that for this group of residents or general practitioners, that there should be some formal training, and they have to understand the ECG basic concepts, as well as to make the diagnosis of routine ECG problems. I was planning for a long time, and I was not getting a proper forum, and I was also worried how would be the response. So when Dr. Rudrakshi and Tapidia, they asked me to conduct some cardiac activity, I thought, let it be ECG. And considering the response which you have given today here, I think I made the right decision. Now this ECG, I decided to split into two, because ECG can be brought down to a very undergraduate level, or even a DM specialized electrophysiologist also find difficult to make certain diagnosis on ECG. So today's crowd is slightly heterogeneous. We have residents, we have general practitioners, as well as we have BMS and MBBS students, and we have physicians also. So I will try to restrict myself to somewhere in between. It should be a take-home message for everyone, little bit for everyone. But I am really overwhelmed by the response which you have given for this symposium. At the same time, I'd like to thank my fellow cardiologists for putting such a great effort, taking pains to come here and present on different topics of cardiology. And not even one cardiologist was absent. All have respected my invitation, and I thank them all. So the topic which I have chosen is common tachyarrhythmias. Now this you are familiar. The only thing which I would like to add is this is a dedicated conduction system of the heart, where the conduction occurs through a very specialized pathway which facilitates the impulse transmission, and which helps in a very coordinated contraction of the heart, at the same time very effective contraction of the heart. If the impulse arises from somewhere else other than the conduction system, naturally it is more disorganized, and the contraction is naturally more disorganized. Before going to the tachyarrhythmias proper, we have to understand what are supraventricular ectopics. The mean supraventricular ectopics is above ventricles. Above ventricles means AV node and above. Anything below AV node is a ventricle, is a his bundle, Purkinje fibers, or a ventricular myocardium. That all comes in the infraventricular side. But the supraventricular is a atrial as well as the AV node, because this is the way the ECG can differentiate between the supraventricular and the ventricular types. Now the supraventricular ectopics. What are the supraventricular ectopics? Ectopics means any beat which comes prematurely. A normal sinus rhythm, if the rhythm is if it is coming at 70 beats per second, something which comes prematurely, an unexpected guest, that's a supraventricular ectopic. So here you will see that now this beat, you can see the rhythm strip. This beat is unexpected. Normal beats are coming like this. This is a normal sinus beat. This is unexpected. So a beat which comes prematurely is a premature beat. So first of all, we have to see that beat which is an extra beat, see in clinically pulse will be irregular. The pulse irregular means the beats are not coming in a regular interval. So the beat can come prematurely or the beats can come late. If it comes prematurely, it is called as the ectopic. If it comes late, it is called an escape beat, because the upper higher center fails to fire, the lower center, it waits whether it will come. If it doesn't come, then the beat. Suppose if there is sinus pause, Dr. Toshniwal has shown, if there is a sinus pause, if there is sinus node fails, AV node waits for some time and then it fires. So it comes late. So it is an escape beat. As against this, the premature beat comes prematurely, comes before the normal RR interval. So this is the distinction. Both beat morphologies can be same. A junctional beat and a junctional ectopic, ECG wise will look the same, but the ectopic will come prematurely and escape beat will come later. What are the characteristics of the supraventricular ectopic? They look similar to the sinus beat. They look similar to sinus, meaning it is a narrow QRS. See, supraventricular beat is arising from the atrium. It doesn't go to the ventricle from any other place, but it goes to the normal conduction system, goes to AV node, and then follows bundles, his bundle and Purkinje fibers. So its morphology is similar to the sinus beat, but slightly different. So it is a narrow QRS because it travels along the dedicated pathway. So it's a narrow QRS beat. Because it arises from a site slightly different from the sinus node, the P wave morphology you will see is slightly different from the sinus P wave. So the beat which comes prematurely, the morphology is similar to the sinus beat but not exactly sinus beat, and which has a slightly different configuration than the sinus beat is a supraventricular ectopic. And now depending on the P wave, this supraventricular beat can be localized from where it is arising. Now here this is similar to the normal sinus P wave. So it is somewhere in the atrium following the same course of the normal. So this has to be a right atrial supraventricular ectopic. For a left atrial supraventricular ectopic, usually the P wave is inverted in lateral leads V5, V6 and 2, 3 AVF. If P wave is inverted in inferior leads and lateral leads, it is a left atrial ectopic. If P wave is inverted in only inferior leads, then it is a junctional or AV nodal ectopic. So you will have P wave which is inverted in, depending on the which lead it is inverted, you can localize where this supraventricular beat is arising. In junctional ectopic, usually the PR interval is narrow, shorter than the sinus interval. But in right atrial and left atrial ectopics, the PR interval may be normal. So these are the characteristics of a supraventricular ectopic which you have to understand. But one thing you have to remember, this is just academic exercise. Supraventricular ectopics in general, unless they cause significant symptoms, don't deserve any treatment. So they need not be treated. This one has to understand. And the diagnosis is only because the patient feels a third suddenly. He feels a third and he is worried. So you have to do an ECG, show that it is a supraventricular ectopic and you can forget about it. As against this, if it is a ventricular ectopic, you have to go further and see whether the patient has any reason for it. Now coming to the ventricular ectopic. In ventricular ectopic, unlike the supraventricular ectopic, the focus is in the ventricle. So the conduction of the impulse is not through the traditional dedicated pathways of SA node, bundle branch, his bundle, but the conduction is from muscle to muscle because it is arising from the muscle, left ventricle or right ventricle. So it is muscle to muscle conduction, and that's why here the conduction is slow. Like if you are traveling on a model road, you go fast, and if you are going in a gully board, the conduction will be slow. Similarly, because this is a muscle to muscle conduction, it is a wide QRS, unless as against the supraventricular ectopic. Now the first thing is a wide QRS. One more thing I forgot to tell you about the supraventricular ectopic is a pause which follows it. This is a pause. After the ectopic, there is a pause. Now, how much is this pause? This pause, it is called as an incomplete pause. Incomplete pause means what? Incomplete pause means if you take a sinus beats, if you take 3 sinus beats, whatever is the interval between them, and if you take 3 beats of this, means this beat, this beat, this beat, if you add this, means interval between this beat, between these 2 sinus beat and this, if you add this, and if you have these 3 sinus beats, then normal sinus beat 3 beats interval is slightly more than these 3 beats. Why? Because the supraventricular ectopics, when it is activated, it also goes to sinus node and depolarizes it. So sinus node is depolarized early and it fires early. That's why the pause which you get is incomplete. That means the normal sinus beat would have come here, but in supraventricular ectopic it comes slightly before. So this is called the incomplete compensatory pause. This I want to tell you as against the ventricular ectopic. In ventricular ectopic, the first criteria I told you, it's a wide QRS. Wide QRS already has been discussed. What is a wide QRS? Wide QRS is 0.12 second or more. That means 3 divisions or more. It is a wide QRS. So this is a, again this has to come prematurely. That's why it is a premature ventricular. See, ectopic, premature beat means the same. As against this escape beats means which comes late. So this has to come prematurely. Means before the sinus beat. Now here, if you see, now I would like to illustrate here what is a complete compensatory pause and what is an incomplete compensatory pause. Now if you measure the distance between these 3 beats, and if you measure the distance between these 3 beats, you will see this is same or this is slightly more than these 3 if you merge. So this is called as a complete compensatory pause. Got it? So this is a complete compensatory pause, because here the ventricular ectopic impulse doesn't go back to the sinus node to depolarize and activate it. That's why you have a complete sinus pause. Another criteria for a ventricular ectopic is absence of the P wave. So absence P wave, wide QRS, complete compensatory pause, a beat which comes prematurely is a ventricular ectopic. Now sometimes you can have an incidental P wave. Incidentally, you can see a P wave, but it is not a true P wave. It looks like a P wave. Sometimes in this bit, you have a P wave here. Can you see that P wave is here? So P wave is coming after the QRS. In other words, this ectopic is the most common cause of AV dissociation. If you are an examiner, for the students who are appearing, if the question is asked, what is the most common cause of AV dissociation? It is not complete heart block. You feel it is a complete heart block. Complete heart block is not the diagnosis. Ventricular ectopic is the diagnosis, because this ventricular ectopic is definitely more common than the complete heart block. And this is, if the P wave is there, then you have a single beat where there is a AV dissociation. So these are the criteria of ventricular ectopics. Now these ectopics can be bigeminy, trigeminy, quadrigeminy, couplet, run-off waiting. Interpolated, that I won't go to. There are, now this is a beat. Every alternate beat is an ectopic. So this is called as a bigeminy. That means if you feel the pulse, you will get in couples, thak thak, thak thak. That is a bigeminy. Okay, this is a pulses bigeminy, and the commonest cause is ectopics coming in bigeminy. Now this is in trigeminy. Every third beat is ventricular ectopic. So you have a triplet, thak thak thak, pause, thak thak thak, pause. So this is in trigeminy. Now 2 beats, 2 ventricular beats which come in succession without any intervening normal QRS, this is called as a couplet. This is a more serious condition. Isolated ventricular ectopics usually may not need treatment. They need treatment only if there is underlying structural heart disease or if they have a serious symptoms. While couplets, yes, it deserves more attention. This may herald a more serious arrhythmias in future. So 2 ectopics coming in succession is called as couplet. If 3 beats come in succession, it is called as a ventricular tachycardia. So 2 beats is a couplet, 3 beats in succession is called as a ventricular tachycardia. That is the shortest ventricular tachycardia you can have. Now this is again very important, whether it is a unifocal ventricular ectopic or it is a multifocal ventricular ectopics. I mean ectopic arising at one particular site and ectopic arises at 2-3 sites. So depending upon the ECG, you will know whether it is a unifocal ventricular ectopic or a multifocal. Now here you will see this beat and this beat. The morphology is changing. So you feel the morphology is changing, that's why it is a multifocal ectopic? No. See, unifocal ectopics also can have a different morphology. It is the coupling interval. What is the coupling interval? Interval between the normal beat and the ectopic. This interval determines whether it is a unifocal or a multifocal. Okay, if this interval is constant, then it is a unifocal, irrespective of the morphology. Morphology usually is different, but not necessarily. So what is important is the coupling interval. If the coupling interval is different, then it is a multifocal ectopics. I mean, there are multiple foci. This is very important. This is very important because you will see subsequently in tachyarrhythmias whether it is a unifocal or multifocal, that can determine the treatment. So this is about unifocal. Now coming to the morphology of ectopic. Whether the ectopics has a left bundle branch morphology or whether it is a right bundle branch morphology. This is very important because this tells you the origin of the ventricle. If it is a left bundle branch morphology, then the ventricular ectopic is arising from right ventricle. Okay, it is opposite. LBBB, ventricular ectopic is arising from the right ventricle. RBBB, ectopic is arising from the left ventricle. This is very important because in certain arrhythmias, if you can localize where the ectopic is arising, and now we have treatment available of radio frequency ablation, you just give a small shock there and you can cure ventricular tachycardia. So now coming to tachyarrhythmia, this was very essential. Now we coming to tachyarrhythmia. Tachyarrhythmia is a huge topic. It is a huge, most complex topic, and the topics which has interested and intrigued everyone right from the undergraduates to electrophysiologists. But I will try to restrict myself to very common tachyarrhythmias which we see, because we should not go into details. So when you see a patient with tachyarrhythmia, what do you see? You see whether it is a regular or irregular. Second, whether it is a narrow QRS or whether it is a wide QRS. And third, whether it is preceded by a P wave or a not P wave. Only these three things will help you to make a proper diagnosis of tachyarrhythmia. Regular, irregular, narrow QRS or wide QRS, and whether there is a P wave preceding each beat. Now this is the, let's see what arrhythmia is this. Definitely it is a tachyarrhythmia. The heart rate is more, the heart rate is somewhere to the tune of 100 per minute. 150 per minute. There are two divisions, 300 over 2 divisions, that is 150 per minute. Is it narrow QRS? Naturally it is a narrow QRS. Is it preceded by a P wave? Yes, there is a definite P wave. You can see P wave here, you can see P wave here, P wave. So normal P, normal QRS, this is sinus tachycardia. So sinus tachycardia is usually in response to something. It is not an arrhythmia. It is in response to something. It can be response to hypotension, it can be response to some infection, it can be in response to heart failure, it can be in response to fever, thyrotoxicosis and other conditions. So sinus tachycardia usually does not need any treatment, however the fast heart rate is. Remember, many times I get a referral that rate is 150. Should we give adenosine? Should we give verapamil? Never treat sinus tachycardia, because it is body's natural physiological mechanism of increasing the cardiac output. So never treat sinus tachycardia unless if you feel this sinus tachycardia is going to harm the patient, like if the patient has a compromised left ventricular function. If he has ejection fraction 20-30, if the sinus tachycardia is lasting for a long time, that he might go into heart failure. This is a time you might think of bringing down the heart rate. But most of the time, sinus tachycardia needs no treatment. So it is very important that you have to diagnose this as a sinus tachycardia and not any arrhythmia. In infants, neonates, the rate can go as high as 200, but it could be sinus and it doesn't need any treatment. Now, which is this arrhythmia? Very rapid heart rate, more than 150, it is around 160, 170, narrow QRS. Is there a P wave? No P wave. Is it regular or irregular? Clock-like regular. You will say it is a clock-like regular. So clock-like regular, no P wave, very fast heart rate, narrow QRS. This is called as a supraventricular tachycardia. Previously, the electrophysiologist called it as a AV-NRT, AV nodal reentrant tachycardia. I will tell you what is the mechanism of AV nodal tachycardia. This is a very classical example. This is common in females, young females, and typical history we will get is sudden onset of palpitation, sudden offset. That means the light लावल्यासारखं धड 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 सुरू होतं, light बंद केल्यासारखं बंद होतं. If you get this classical history in a young female, 99% of the time it is supraventricular tachycardia. This tachycardia needs treatment. This usually is not a life-threatening. Although the rate looks life-threatening, it is not a life-threatening condition. Patient may have transient dizziness, may have little fatigability, but he can pull on for many hours to days, and usually not life-threatening and can be managed easily. I won't go into the drugs, but you know verapamil, adenosine, these are the drugs. So this is the name SVT or AVNRT. Now what is the pathophysiology? Now normally what happens, this is the AV node. Normally the supraventricular impulse, when it goes to AV node, in normal persons, the AV node has a uniform conduction characteristics. That means all part of the AV node has a normal electrophysiological characteristics. That means the speed of conduction and the refractory wave. But in certain patients, you have a dual physiology. Means part of the AV node conducts fast, part of the AV node conducts slow. Part of the AV node has a long refractory period, part of the AV node has a short refractory period. This physiology is called the dual physiology of the AV node. This is what is the triggering mechanism of supraventricular tachycardia, and why this is what is called as AV nodal reentrant tachycardia. So what happens in the normal sinus beat? Normal sinus beat comes like this, it goes like this, it attempts to go like this here, but because there is another, the sinus beat has also come through where this is blocked and the tachycardia is not generated. But sometimes you have an ectopic. PAC is a premature atrial contraction. Sometimes you have an ectopic. What this ectopic does, this ectopic goes around one pathway, slow conducting pathway. Then when it comes back, this is a other pathway, it forms excitable. So it goes back, again it comes down. So you have a re-entrant circuit developed, and this generates tachycardia. So a critically timed ectopic, it finds itself one of the pathways excitable and one of the pathways not excitable, and you get a circuit. This is called as the AV nodal reentrant tachycardia. Now the characteristic is, when you have this circuit, part of the impulse goes to the atrium, at the same time it goes to the ventricle. So atria and ventricles, they are stimulated simultaneously, they depolarize simultaneously. So P is superimposed on QRS. So you don't see a separate P wave in AV nodal reentrant tachycardia or supraventricular tachycardia. Rarely you can have, so this is again graphically distributed same, the impulse same, this I won't go into detail. Now rarely you will see here, now a novice, a routine resident tells me this is an anterior ischemia. This is not. See, what is the rate? Rate is very fast. Is there a preceding P wave? No. What this is a retrograde P wave. If you see this is an inverted P wave. I told you AV nodal, you have an inverted P wave. So this P wave is coming after the QRS, because the atria sometimes they get depolarized after the ventricle. You have a P coming after the QRS, and which can be mistaken for ST depression and can be wrongly treated. This does not need any anti-ischemic treatment. You just treat it with adenosine, verapamil, and the ECG will be fine. So this has to be, this one has to bear that whether we are dealing with the retrograde P wave and not ST depression. Now coming to the most common arrhythmia is atrial fibrillation. Now again I told you, when you see rate is fast, rate is fast. Is the rhythm regular or irregular? It is irregular. Is there a P wave? No P wave. So if there are no P waves, you have three types of arrhythmias. One, I told you supraventricular tachycardia, you don't see P wave. Second, in junctional tachycardia, you don't have a P waves, because again P is merged in QRS. And third, in atrial fibrillation. In atrial fibrillation, there is a disorganized atrial activity. What is atrial fibrillation? There are multiple foci in both atrium which fire. They continue to generate impulse at a very fast rate. And some of the intervals they penetrate the AV node, some intervals don't penetrate the AV node. So some intervals, some impulses reach the ventricle, some impulses don't reach the ventricle, because the atria is firing at the rate of 300-350 per minute. And the AV nodal refractory period doesn't allow all the impulses to go through the ventricles. Only some impulses are conducted. So you have irregular rhythm, because sometimes some impulses are conducted, some impulses are not conducted. And that's why also in some impulses finds one particular pathway, some impulses find some other pathway, which is this thing. That's why the QRS morphology also slightly changes in atrial fibrillation. Remember, the diagnosis of atrial fibrillation is a narrow QRS tachyarrhythmia, rhythm is irregular, and absent P wave. Only these three criteria. The fibrillatory waves, many times students tend to say it is not atrial fibrillation because there are no fibrillatory wave. Fibrillatory wave is not an essential criteria for the diagnosis of atrial fibrillation. It is just irregular rhythm and absence of real true P waves. If you get a fibrillatory wave, these are the fibrillatory waves, yes, that's a bonus. Okay, then you can diagnose it easily. But the importance is that if they are not there, you have to diagnose it, atrial fibrillation. So most important is the irregular rhythm. If the heart rate is very fast, then that little irregularity may not be appreciated, and you can mistake it for a supraventricular tachycardia. So you have to see very closely whether it is a regular or irregular. Now this is another arrhythmia, very irregular, narrow QRS. Is there a P wave preceding? There is a P wave, but the P wave is of different morphology. Sometimes this is a P wave different morphology, this is a P wave different morphology, this is a P wave different morphology. So 3 or more P wave morphologies if you seen with a narrow QRS rhythm, irregular rhythm which resembles atrial fibrillation. This could have been diagnosed as atrial fibrillation, but you are seeing a P wave. This is called as a multifocal atrial tachycardia, commonest in COPDs. So COPD patient many times have this multifocal atrial tachycardia. This looks like atrial fibrillation, but it is not atrial fibrillation. Now atrial flutter. Atrial flutter is what you call as a sawtooth pattern. There are no true P waves, but you have a sawtooth pattern, and this sawtooth pattern is best appreciated in the inferior leads. 2, 3 AVF, these are the inferior leads. So you will see this. Here you are not able to appreciate. You can miss the diagnosis. If only this lead is given, you can diagnose it as supraventricular tachycardia. Unless you see the inferior leads, you will miss the diagnosis of atrial flutter. So you always have to have the classical atrial flutter. You have what is called as a caudocranial activation. The impulse is lower down in the atrium and it activates upwards. That's why you have inverted waves or a sawtooth pattern in the inferior leads. So this is how you diagnose atrial flutter. Now these are the flutter waves. These are the flutter waves. You can have 2:1 conduction, 4:1 conduction, 3:1 conduction, various conduction differently, depending upon the refractory period of the AV node, how many impulses are allowed to pass through. Now coming to the ventricular tachycardia. Now this is the very serious condition, it needs urgent treatment, needs hospitalization. Now what are the characteristics? Again we go to our basics. Is regular or irregular? Usually regular. Mild irregularity may be there, but usually regular. Narrow QRS, wide QRS. This is wide QRS. Is there a P wave preceding? No P wave preceding. So wide QRS, no P wave preceding, regular tachycardia. This is usually a ventricular tachycardia. I will tell you exceptions in brief because there are physicians, otherwise I would not have dealt with that. Now this is a ventricular, so wide QRS tachycardia is a ventricular tachycardia. So usually there are characteristics, single site in the ventricle, rate is between 100 to 250. There are no normal QRS, P wave is absent, QRS duration. What is wide? 0.12 second or more and a run of 3 or more. Now this is another. Now here the differential diagnosis of ventricular tachycardia, just for a theoretical purpose, I didn't want to discuss it because there are physicians I'd like to discuss it, is if the patient has a pre-existing bundle branch block. Suppose patient has a right bundle branch block and a left bundle branch block, and if he develops supraventricular tachycardia, naturally the QRS is going to be wide. So if patient has a bundle branch block, or what is called as, sometimes because of the tachycardia, refractory period of the bundle, right bundle is so that it gets blocked and you have a wide QRS. So actually it is a supraventricular tachycardia, but to manifest as a wide QRS tachycardia. So here it would be very difficult to make the diagnosis. Now there are certain features which tell you precisely that this is a ventricular tachycardia and not supraventricular tachycardia. First of all, for practical purposes, if it is a ischemic heart setting, ischemia or infarction, don't worry about whether it is supraventricular. It is always a ventricular tachycardia. First thing. Now coming to the ECG characteristics. If the QRS duration is 0.16 seconds or more, then it is always a ventricular tachycardia. Don't worry, don't think what is the morphology, what is RBB, LVB. If the axis is northwest or extreme left, it is always a ventricular tachycardia. No, don't think of a supraventricular tachycardia. If, now this is another pattern, you will see the wide QRS tachycardia, you have precordial leads, all leads showing negative. This is called as a concordant negativity. All V1 to V6, all are negative. If you have a concordant negativity or you have a concordant positivity, all these leads, it is always a ventricular tachycardia. This is a concordant positivity. So all V1 to V6, all are positive. It's a bizarre, more than 0.16, 18 seconds. The axis is gross left. So this has to be a ventricular tachycardia. Now coming to the next one, now ventricular tachycardia, whether it is a monomorphic, means arising from a single focus, or whether it is arising from a multifocus. This is very important. That's why I told you about ectopics. That time I went in detail about the ectopics, how to localize where the ectopic is. Because if the ventricular tachycardia is arising from a single focus with radio frequency ablation, you can cure the ventricular tachycardia and you don't have to take lifelong drugs. If it is arising from multiple foci, then naturally you have no option but to take multiple drugs or go for a ICD implantation. Now this is a ventricular tachycardia. You will see what is the morphology of ventricular tachycardia. It is a right bundle, R in V1, RSR dash in V1, right? If you have a right bundle branch block, it is arising from left ventricle. So naturally it is a left ventricle. You have a gross left axis. So the impulse is going in the left direction. So this is usually arising from the apex of the left ventricle. You can fairly localize it where it arises from. As against this is my own patient recently. So you will remember what is the morphology? Morphology is a left bundle branch block morphology. So left bundle branch block, so it is arising from a right ventricle. What is, now if you go further, the axis, what is the axis? Axis is around 90 if you calculate it is around 90. So it is inferior axis, it is going downwards. So the tachycardia is arising upwards in the right ventricle. So this was the classical right ventricular outflow tachycardia which underwent radio frequency ablation and the patient is fine. Now as against this, now this is a tachycardia where you will see in a particular lead all QRS complexes are similar. If all QRS complexes are similar in a particular lead, it is a monomorphic, meaning it is a single focus. All QRS complexes are similar in that particular lead. As against this, see here, in the same lead the QRS complex is different. If this QRS complex is different in one particular lead, in that lead, if you see, you shouldn't compare this lead with this lead. In that lead, the QRS complex keeps on changing the morphology. It is called as a polymorphic ventricular tachycardia. This is more dangerous. Commonest cause is again ischemia infarction, hypokalemia, myocarditis. This needs very urgent treatment because it might deteriorate rapidly into ventricular fibrillation. Now, torsade de points, or this French word is torsade de point. What does it mean? This means twisting of points. If you twist it, then you have, I will show you what it is. This looks similar to VT. This is somewhere in between ventricular tachycardia and ventricular fibrillation. Now, polymorphic tachycardia can be classified into two types. The polymorphic tachycardia with a normal baseline QT interval and a polymorphic ventricular tachycardia with a wide QT interval. Traditionally, torsade de points means not on the morphology. If the baseline ECG shows a wide QT interval, then it is called as torsades. Otherwise, it is called only polymorphic ventricular tachycardia. This is by definition. So, what is twisting around point? Now, if you see in this lead, if you see here it is positive, then gradually QRS complexes diminish in size and then it becomes negative. So, this is twisting, positive gradually becoming negative. This is torsade de points. This is because of the prolonged QT, resting QT interval is prolonged. So if resting QT interval is prolonged, it is called as torsid, otherwise it is called as a just. Now ventricular fibrillation, you are all aware, what the pulse is, regular or irregular in ventricular fibrillation? Regular or irregular? Commonest they say is irregular pulse. There is no pulse, patient is nearly dying or dead. So the pulse is not there in ventricular fibrillation, remember. So this is because there is a disorganized ventricular activity, and this is about the tachyarrhythmias. Thank you.